presenting a new series, Medically Verbal, where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attend these processes without the guidance of a licensed medical professional. Case number 3: Chief Complaint. A 32-year-old female presents to the emergency department with severe abdominal pain and vomiting. History of present illness includes that she is suffering from abdominal pain that started 6 hours ago, located in the right lower quadrant, which is sharp and constant. The pain is 8 out of 10 in intensity. She feels nauseous and has vomited twice. No history of similar pain, and there aren't any changes in bowel movement or any urinary symptoms. She doesn't have any medical history. She's currently on oral contraceptive pills. Doesn't smoke, does not consume alcohol, works as a teacher. Her mother has a history of gallstone and her father has hypertension. Her BB is 120 systolic, 70 diastolic, heart rate is 100 beats per minute, respiratory rate is 18 per minute, temperature 101 degree Fahrenheit. She is clutching her right lower abdomen, which has a rebounding tenderness and positive McBurney sign. Her cardiovascular region shows regular rhythm and doesn't have any murmurs. Respiration is clear to auscultation bilaterally. Her pelvic examination does not present with any adnexal tenderness or masses. Initial differential diagnosis could be includes appendicitis, ovarian torsion, ectopic pregnancy, gastroenteritis. What do you think is the patient suffering from, and what might be the steps taken for it? 5, 4, 3, 2, 1. If you're thinking of appendicitis, you might be on the right track, because the patient's symptom with the positive McBurney sign is a high consideration for acute appendicitis. To confirm it out, we check anything in our body that would suggest of inflammation or infection. So whenever there is inflammation or infection present, there would be a high white blood cell count, which would be diagnosed or seen in a CBC. At the same time, we'll also check for C-reactive protein levels, which is elevated in case of inflammation. To rule out ectopic pregnancy, we'll make her do a pregnancy test. We'll ask for an ultrasound and a CT of the abdomen and pelvis would be important when the ultrasound wouldn't be inconclusive. If after this too we want to be sure, we'll obviously suggest her to go for a surgical consultation. Management, we'll do a pre-operative preparation by giving her nothing by mouth so that we could prepare for surgery. We'll provide her with IV fluids to keep her hydrated. We'll administer metronidazole so that we could reduce the risk of post-operative infection. Of course, an appendectomy would be done because that is the definitive treatment. It is performed through laparoscopic methods or an open surgery. Post-operative care, of course, she might be suffering from pain, so we'll give her with analgesias and we'll monitor for complications to see any hemorrhage or infection or formation of any abscess. We'll make her, resume her diet, starting with some liquid first and building up the tolerance until she can eat solid food back. Follow-up would be done by wound care. We'll instruct her how to take care for the surgical site, and we'll obviously ask her to not lift heavy objects for quite a certain amount of time. Alternative diagnosis were ovarian torsion, so for that we could do a pelvic ultrasound with Doppler studies, and for gastroenteritis, so in that case usually diarrhea and a diffuse abdominal pain is found out, but this one was localized in the right lower quadrant. Hope you guys liked the case study of today. Do not forget to take the screenshots or sum up later, or you can always revisit. Thanks for watching. Corrections or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.